Development of the lower respiratory tract begins to form during the 4th week of development. It begins as a median outgrowth laryngotracheal groove from the ventral wall of the primitive pharynx foregut. The groove invaginates and forms the laryngotracheal respiratory diverticulum. A longitudinal tracheo-esophageal septum esophagotracheal develops and divides the diverticulum into a dorsal portion made up of primordium of oropharynx and esophagus, and a ventral portion made up of primordium of larynx, trachea, bronchi, and lungs. The proximal part of the respiratory diverticulum remains tubular and forms the larynx and trachea. The distal end dilates to form lung bud, which divides to give rise to lung buds, primary bronchial buds. The endoderm lining gives rise to the epithelium and glands of the respiratory tract. The surrounding splanchnic mesoderm gives rise to connective tissue, cartilage, and smooth muscles. The opening becomes the laryngeal orifice. The epithelium and glands are derived from endoderm. Laryngeal muscles and cartilages, except epiglottis, develop from mesoderm of 4th and 6th pharyngeal arches. By the end of the 5th week, the bronchial buds on the right side develop into 3 buds while the left develop into 2. The 2 primary bronchial buds grow laterally into the pericardioperitoneal canals. Bronchial buds divide repeatedly to form the bronchial tree. The right main bronchus is wider and more vertical than the left. The main bronchi subdivide into secondary then tertiary segmental bronchi, which give rise to further branches. Maturation of the lungs is characterized by 4 periods: pseudoglandular, canalicular, terminal sac, and alveolar period. In the alveolar stage, for proper gas exchange, 3 things must occur: surfactant production, transformation to gas exchange phase, and establishment of circulation. By 24 weeks, terminal sacs are lined by squamous type 1 pneumocytes and rounded secretory type 2 pneumocytes that secrete surfactant. Surfactant production begins by 20 weeks and increases during late pregnancy. Premature babies at 24 to 26 weeks may suffer respiratory distress but may survive with intensive care. 95% of alveoli develop postnatally. About 50 million alveoli are present at birth. From 3 to 8 years, the number increases until about 300 million alveoli are reached. With the first breath, surfactant prevents high surface tension. Without it, alveoli collapse atelectasis. The lungs at birth are half filled with fluid from amniotic fluid and glands. This is cleared by colon 1. Pressure during delivery 2. Absorption into pulmonary capillaries and lymphatics. Clinical correlates includes 1. Esophageal atresia, a birth defect where the esophagus ends in a blind pouch and does not connect to the stomach, causing choking, coughing, and feeding difficulties. Often associated with tracheoesophageal fistula. 2. Tracheoesophageal fistula TEF, an abnormal connection between the trachea and esophagus allowing food to enter the lungs, causing aspiration and pneumonia. 3. Tracheal stenosis and atresia. Stenosis is narrowing of the trachea. Atresia is complete absence or closure. 4. Congenital lung cysts, abnormal lung tissue forming cysts that may cause infection. 5. Agenesis of lungs, failure of lung development. Unilateral may survive, bilateral is incompatible with life. 6. Lung hypoplasia, incomplete lung development leading to severe breathing problems. 7. Accessory lungs, extra lung tissue due to anatomical variation, usually asymptomatic. 8. Respiratory distress syndrome RDS, a condition in newborns caused by lack of surfactant leading to collapsed alveoli and breathing difficulty. Conclusion and summary: the respiratory system develops from the foregut. Epithelium arises from endoderm, while connective tissue, cartilage, and muscle arise from mesoderm. Faulty partitioning leads to esophageal atresia and tracheoesophageal fistula.
If you found this helpful, make sure to like, share, and subscribe, and I'll see you in the next video.